Hello, everybody. Thank you for joining us on this Thursday. I hope everyone's doing great and has had a great week. I'll introduce myself. I'm new to everyone on this call, but my name is Lindsey Riley, and I'm the National Director of Outreach for Integrative Life Network. We have your presenter here, of course, William, and an old face to all of you, a familiar face to all of you, Tara Young, Senior Director of Marketing, is also here with us today. We're going to wait just a couple of minutes for people to start popping on, and then we will get started here in just a couple of minutes. While we wait, I would love to know where all of you are Zooming in from. So please, in the chat, if you could just write where you're from, we would love to say hello and see where our audience is. Ohio. Oh, all of us. Ohio, Washington, D.C. We have Virginia. Hi, everybody. Arkansas, Georgia, South Carolina, South Africa. Wow. Nevada, California, Tennessee, Texas. Awesome. Wow, thank you all so much. This is great. It's great to see where everyone is from. We're here in Nashville and it is hot, y'all. It's already this morning when I woke up, it was 89 degrees outside. So it's been hot. I think the rest of the country is pretty warm as well. We have Palm Beach, Florida, Vermont. Great. Thank you all so much. All right, we're going to get started. It's 2 minutes past our time. Yay, my home state, Tennessee. Awesome. All right, I'm going to share my screen. We're going to do a few housekeeping things to get y'all started, and then William will get started here once we are finished with that. So you're in the right place if you're here for ethical considerations and addiction treatment. That's what William will be talking about today. My computer is slow here. There it goes. So this is brought to you by Integrative Life Network. So we're a premier family of trauma-focused treatment centers for substance use, mental health disorders, eating disorders, and intimacy disorders. Hopefully you've heard a little bit about us. We do have a few programs under our Integrative Life umbrella here. We have Integrative Life Center, which is here in Nashville, Tennessee. We have Begin Again Institute in Boulder, Colorado. And then we have Sauna at Stowe in beautiful Stowe, Vermont. So this, William is going to be speaking to you today, of course, and it's from Integrative Life Center in Nashville. Just to give you a little bit of information about who we are. So we're an intimate, privately owned treatment center. We're duly licensed, so we can take primary mental health as well as primary substance use disorders. And then we do treat co-occurring disorders from a trauma-focused perspective. ILC offers a full continuum of care. We have residential all the way down through IOP. We also do have some supportive housing and dedicated services for women's eating disorders and also men's intimacy disorders. Right there on the bottom of your screen, if you'd like to make a referral, there's the address to do so. And to learn more about us, our website is also there at the bottom of your screen. Now, kind of not the fun stuff, but stuff that we have to do is giving you some reminders about our CEs and how you can get those certificates. So for attendance, you must be registered in your own Zoom with your own unique link. So please make sure that you are signed in to that. You would have received a confirmation email from Zoom when you signed up for this webinar. You must remain on the webinar the entire time for CE credit. So we can see when you join and leave. I know that feels a little big brotherish, if you will, but in order to receive that credit, we do need to make sure that you're on the webinar for the entire time. You must complete the CE evaluation on the webinar and end page. So once you end this webinar, once we end it for you, you will be taken to that survey, and then please fill out that evaluation. Please do allow us until next week, next Wednesday, June 26th, to get those certificates to you. It just takes us a little bit of time. So thank you for your patience in advance for that. This webinar is being recorded currently, so we'll send you your certificate as well as the recording to this from our YouTube channel. Unfortunately, CEs are not available for somebody who watches the webinar. Feel free to share it if you'd like for information purposes. We're not able to give CE credits for that. If you have any questions, Allie, who's not on here today, but she's another wonderful, one of our marketing coordinators, she's happy to answer any questions you might have. So please do email us if you have any questions, and then you will hear from her specifically for those certificates. All right, last but not least, let's introduce William here and then he'll get started. So William Feck is a licensed professional counselor with mental health service provider designation. He formerly worked as a school counselor in an elementary school before transitioning to a clinical setting. He is a faculty member and lecturer at Middle Tennessee State University for the professional counseling program, supervising practicum and teaching courses such as theories and addictions. William is pursuing a PhD in clinical counseling at Trevecca Nazarene University and is currently working on his dissertation pertaining to combat exposure, relationship-specific attachment styles, and post-traumatic cognitions as predictors for PTSD. He is trained in brain spotting phase 1 and 2, an intervention he uses with the clients here at ILC in Nashville. Additionally, he is a nationally certified counselor and certified sex addiction therapist. One more thing I do want to mention before I turn it over to him is that we will be taking question and answers the last 15 minutes of this presentation. Please go ahead and put those in the Q&A section, not the chat section, just so we can see them, we can mark them once we answer them, and we'll try to get to as many questions as possible. So without further ado, thanks for being here, William. You can go ahead and take it away.
All right. Hello, everybody. It's good to be with you. We are in Tennessee heading into the afternoon, but I know different time zones are present. But it's good to be with you today. Honored to be able to be sharing about ethical considerations in addiction treatment. As Lindsey was talking about, this is mainly coming from a place of working in higher levels of care. Worked at Integrative Life Center for several years now. That's given me the opportunity to really walk with clients through those various stages and those levels of care and get to see the type of care that they need, support they need as well. And then, of course, seeing them transition into outpatient. So for the most part today, it's going to be a blend of kind of aspects and considerations in residential PHP, IOP, but then really kind of broaden the scope in the latter half of the presentation, getting into, regardless of the level of care that you're operating from and in, things that are applicable to clientele in that setting. So as discussed, as far as the objectives go, we're really going to kick this off by talking about the informed consent, spending actually quite a bit of time with that, because that tends to be really how to set the scene for a very successful treatment. Taking the time to kind of go through, as far as ethics go, really what needs to be a part of the informed consent process, really getting into documentation too. I know that's not always the favorite aspect of our job. Some people like to really get into documentation, knowing the nitty-gritty and how to be more efficient. I don't necessarily mean that just from a Joint Commission standpoint or insurance standpoint, but really clinical documentation for both our benefit as clinicians and that of clientele, really informing them of what is the documentation and using that actually to help them understand the progress that they're making each step of the way in their recovery efforts. And then, as I already mentioned, broaden the scope here of getting into more specific ethical principles to talk through. Some of that is applicable to any clientele, regardless of presenting issues, but definitely getting in to much more relevance with those who are actually working through various types of compulsive behaviors or impulsive behaviors that fit in the addictive sphere. So we're going to start this off by, like I said, talking about informed consent and getting into the legal and ethical aspect of this. And I can recall back when I was in my own undergrad for psychology, and first day of class, psychology professor walked in and he talked about the importance of not just operating from being in a legal stance as a clinician, of course, always following the law, but also operating a step above that and being ethical. Because if we think about it, I mean, if we're only worrying about the legal issues, that is pretty much the minimal standard of living and the minimal standard of operating as a counselor. And so when ethics come into play here, we're really taking a step beyond just legal issues and really trying to promote the welfare of our clientele to set them on a path of healing and change that they aspire to. So with that context, talking about informed consent, we know that this happens in many, many stages throughout a client's journey, whether that's an outpatient, whether that's in some type of treatment setting as well. And typically their days tend to be numbered when it comes to treatment. They're with us for a designated amount of time. But ideally, we have that number, those days in mind as we're informing them of how things are going to go as far as the therapeutic process. So I like to use the analogy when it comes to informed consent of really taking into consideration if we were medical doctors, and many of us, I assume, are along the lines of licensed professional counselors, social workers, there's licensed marriage and family therapists likely here, potentially even some psychologists as well. So many people fall under that mental health discipline, and then we have those various professions under that umbrella. But as we're thinking about informed consent, thinking about it more from a medical model and thinking, if you were to be a patient, you had this using an analogy here, but if you were to be a patient and have this pain in your stomach, your abdomen, have no idea what in the world is going on, and of course you know the right professional, at least you have an idea of which professional to go to get those services offered for you, to at least provide you some explanation. There's confidence that you have in them that they can tell you what's going on, and above and beyond that, can they treat it? And so let's say that as you're talking through your presenting issues, the doctor with a lot of confidence is like, yeah, I can definitely help you with that. I can treat that. Doesn't really give you much more than to just say, well, we got to use some anesthesia, put you under. You follow through with that, and then you end up waking up with quite a large incision from one side of your abdomen to the other. You see the stitches and you're like, what in the world happened here? I was very clear about, what my issues were, kind of presenting issues, but I had no idea what this treatment was going to entail. And so as you kind of come out of this, you're learning throughout time what was involved, the surgery that was involved, and you're really appalled that you had no idea what this treatment was going to take until the latter end of it. No one really upfront told you what this was going to involve as far as treatment goes, and even as far as recovery goes, because even after treatment, there's quite a recovery process. And so that's definitely on the more extreme side and getting into what would even consider medical assault. We have little worry with that since we're not making any kind of incisions in folks, but I use that analogy because in a sense, as mental health professionals, we do kind of make incisions within the psyche, and we do some kind of prying and exploring. And along those lines, people don't quite know what recovery and change and healing is going to look like. I mean, it's the whole cliche of things get worse before they get better. And it's very important at the beginning to let them know what the therapeutic process looks like, especially that to do a lot of healing work, it can be pretty unpleasant. So prepping them mentally to know what this involves, and then how are you going to go about treating? And this will come a bit later, just kind of setting the scene here about the theoretical model that you mainly operate from, although we tend to be pretty eclectic and integrative, but having the ability to explain at least enough to where in their understanding, they're like, yeah, this, I want to go about treating kind of my presenting issues from this way. Okay. So informing them from the beginning, giving them from an ethical standpoint, the autonomy to make decisions about what kind of treatment that they're getting, and they can decide if that fits for them. I mean, if we look at the second bullet here, clients have a right to know the therapeutic process due to them actually purchasing a service, even though we might often not think of it as a service, but it is as a service from a professional. So with this, in the beginning, this conversation, there's a lot happening at the beginning, but all along the way, we're informing them of really decisions we're making, not on behalf of them, but ideally in collaboration with them. Because as people are beginning that healing work, if you've been in this for a while, we find out new things about the client. Sometimes the client finds out new things about them. And that sometimes needs to alter the course of treatment, or it means that there's a shift in modality. Whereas you were going about it from more of a CBT stance, the more that time goes on, the more you're like, this really needs to be pretty targeted with something like EMDR. Well, that involves quite a different experience in the therapeutic process. So as you're doing that, you're really informing them of what you're experiencing, what the data shows per assessments, and then also any kind of alterations in treatment. And so to provide them with that autonomy, and especially in considerations of different learning styles and just the way we kind of gather information and make decisions, this is coming from both a written document, of course, that they're signing. Many of us practice that very well, but not just relying on words on a document. We can, if you think about all the things that we sign up for, we just kind of put our signature at the end, oftentimes, especially the busier we get, the more distress that we get in, especially when there are crises going on in our lives. We're like just kind of checking yes to whatever someone says that might be helpful. So in addition to matters being written, this is a pretty verbal process as well. In response to what I just said, we found in residential, typically people who are coming to residential, there's quite the impairment in multiple areas of their lives. And so socially, there's impairment. They're in their relationships with loved ones. Sleep and appetite has become impaired. Their work or occupation has been impacted if they're in school. So there are these various areas of life where there's this impairment and crisis, and it's just very easy for folks to just kind of say yes to whatever. And so due to that, once we've gotten people in residential to help with this informed consent process, we really provide a clinical orientation within the first week. And we actually like to wait a few days after they've admitted. So of course, they're getting this information on our website about treatment modalities. They're having a conversation with our admission specialists, intake specialists. They're getting this on the forefront, but as they're kind of stabilizing in residential, especially with their psyche, and able to attend much more to what the treatment course is going to look like, we provide an hour-long orientation about what our treatment modality looks like, helping them to really connect the dots as well with how treatment is going to go. Because what we found in working with addictions, and this is just our treatment philosophy here, is we very much don't want to just treat the symptom of addictive behaviors or compulsive or impulsive behaviors, but really want to treat the cause. And so from our perspective, we have various different theoretical models, but from our perspective, we really want to look at childhood experiences very much from an attachment theory lens of looking at from a non-blaming model. It's not about did you have good parents or bad parents, but what experiences contributed to addictive behaviors, which from our stance is kind of you living out this hyper self-reliance of not going towards people for support, but turning towards a substance or a behavior to experience some type of affect regulation. And so we want to hear from clients of, as you're getting to know this process, does that seem like that's going to be a good fit for you? I know they've definitely committed, but that opens the door for any kind of questions they might have, misunderstanding, and if we need to as well, kind of shift any kind of individual therapy and approaches. Additionally, the other part of the clinical orientation is sometimes the experiences that we facilitate don't quite kind of logically connect the dots between what do certain experiences have to do with addictive behaviors. Really good example is we offer art therapy, music therapy. We have Indigenous therapists who provide those practices, especially we have quite a few Indigenous clients. And so a sweat lodge might be facilitated. Well, what does that have to do with an addiction? And so in those clinical orientations, we help connect the dots between our philosophy of connecting the mind and the body, offering an integrative approach to treatment, and helping them to understand as they go into a sweat lodge, if they're willing to do that, to understand how that's facilitating healing or the potential for healing in their recovery process. Okay. So I say all that, and please feel free to, as I'm talking, put in kind of comments and questions. We'll have time at the end to get into some of those. We'll have a limited time, but whatever we can get to, we'll try to as you questions arise with that. So I do have on the left side, you can see the legal, ethical, and compliance aspects of informed consent. Like I said, we want to go well beyond just the legal matters of informed consent and promote the most autonomous decision-making possible. And with that process, really make sure that what we can offer, and typically our goals that we kind of get defined through residential, are aligned or need to be kind of more aligned with the goals of the patient as well. And then just from an administrative standpoint, making sure that it's been documented well that this process has taken place. So we're going to continue on with more specifics of informed consent and take a bit of time to actually walk through these in the process. And like I said, ideally, this is written out in a document. That's the legal aspect of this. More of the ethical aspect of this is talking through it as well, spending time. And I get that sometimes clients really want attention given to the actual presenting issues, but I've just found that if this does not take place from the beginning, there tends to be quite a bit of confusion sometimes of why did therapy go this way, or not understanding the outcomes that they had, maybe a disappointment from time to time. And so this really sets the scene, I would say, for quite a bit of success, even though it's a lot of front end work. It's definitely worth it, even if it takes up some time away from the actual crisis that they're trying to address. Yeah. So as I mentioned with the therapeutic process, we'll get to this in just a bit, but getting into that things do get worse sometimes before they get better, understanding why we're taking time right now to talk about informed consent instead of the compulsive or impulsive behaviors that you're wanting to engage in, taking time for assessments. If we look historically, assessment has been misused in the past from time to time. This happens when culture, race, ethnicity is not always taken into account. And the publisher Pearson actually has created some really great webinars as well that you can watch on YouTube about being very culturally informed about the use of assessments as well. And sometimes those are normed on a white population, and then you're utilizing them for folks or people of color. And the results are just not quite normed on them. And so it can lead to inappropriate interpretation and treatment processes as well. So we want to make sure that any kind of assessment that we're utilizing, the norms have been established, the cutoff scores, the ranges can represent the population well. An example of that is we actually do have quite a bit of Orthodox Jewish clients at Integrative Life Center. And one of the things is sometimes our assessments do not represent well the population when it comes to especially family of origin and relationship kind of labels and categories as well. So we're really taking that into account even when we do use assessments, putting them in the proper place in interpretation. The therapist background, I certainly don't mean necessarily our personal lives, although that does come into play sometimes in recovery, which I'll talk about later, but it is very important to inform them of our competency, our training, our education in residential treatments. There tends to be a lot of therapists involved, so that does not mean sitting down and giving them a piece of paper with all of our credentials, but taking the time as briefly as possible to tell them the training and credentials offered and why we're competent, at least in what we're facilitating in that moment. Cost, of course, upfront are very important. No surprises there for clients on the back end, but ideally know pretty upfront before they commit to anything. Length of therapy and termination. I'm going to get to this in just a moment in terms of research, but it's very important that folks do understand and have realistic expectations on, especially in higher levels of care, if they're coming to a treatment center that is basically defaulted to 28 days per level of care, expectations need to be realistic. about what's going to come out of those 28 days. And obviously, everybody is different, and so many extra therapeutic factors affect outcomes such as hope, acuity, the previous treatment attempts, all of that comes into play. And yet we can still have discussions about typical outcomes with 28 days. And like I said, that ideally is based off research, which I'm going to show you in just a moment. Consultation, we're informing them that, of course, there is confidentiality, and yet in the same treatment center, we do have the ability to consult with colleagues without a release of information, as long as it's within the same institution. Interruptions in therapy, that can be taken from various aspects into account for that. When it comes to benefits and risk, this is pretty important. Many people are coming to treatment well aware of the benefits of this is what I anticipate getting out of therapy, but risk as well need to be discussed. And I don't necessarily mean anything that's severely harmful for a person, but people can be very surprised at, as they're pursuing healing and change, that not all good consequences happen from a person's healing. And this is actually when I do family systems work in group counseling settings, I tend to spend quite a bit of time going through that. For instance, if there is a relationship dynamic that would align with kind of more codependency or enmeshment, and a person is trying to get some help and differentiation of self from a family systems perspective, that is going to be experienced from the other person, the other partner, not as always pleasant, that they're for the first time ever being told no, or they're not coming to them for support necessarily. They're learning how to self-regulate. That can feel very threatening to the relationship. I also think about using just a kind of an example, but I had a client one time, and she, as far as her emotions go, not very expressive and not very in touch with her emotions. And she was married to a man. And as we were doing the work that she wanted to engage in, she was doing quite a bit of grief work. So we were engaging in brain spotting. And through that work, she became much more expressive with her emotions. She had been pretty flat before that. And as she was engaging in more therapeutic and trauma work, she's becoming much more expressive. She's crying more, opening up more. And I think from our perspective, we're seeing the healing happening. We have a very positive perspective towards that. Her husband did not. And from her husband's perspective, he didn't mean anything harmful, malignant regarding it, but he was concerned of, all I'm doing is seeing my wife cry now. Like, therapy is actually making her worse. And because we had a release of information, she actually asked, she's like, can you talk to my husband about what's happening? And that became a 30-minute conversation between her husband and me, of me explaining that this is part of the healing process, that, you've experienced someone who tended to use deactivating strategies from an attachment theory lens, and is now learning the safety and being able to get in tune with her emotions and not just keep them to herself, but also express them to somebody else. So I really put a lot of time into, when someone is healing, what are all of the consequences of healing? And like I said, the benefits tend to get pushed out there commonly. The risk, I think, are very important as well. Okay. When it comes to shifting down to the next bullet, alternatives to traditional therapy, you can take that from various perspectives, but I do think it's important for us to not just push our own discipline as far as how to get help. This is when kind of higher powers come into play for a person's healing. There can be other practices like acupuncture and things like that, but folks need to know if we're utilizing anything that might be considered alternative to traditional therapy, but also there are other options that they have there. This is definitely where case management comes into play, of giving them options for their healing and helping to instill and reinforce their autonomy. I'll be a bit quicker on these last three, but access to files is very important, knowing that they have access to them. I have to remind myself of that, in that as I'm writing documentation, that at any point a client can request that. And sometimes I do write documentation in a way that is professional, and yet sometimes the terminology, it concerns me over how might that be interpreted by the client themselves, but they do have the right to that documentation. Diagnosing in a way that ultimately does benefit them and serves their treatment and recovery as well. And then, of course, confidentiality, which I'll save for more towards the second part of this presentation. So as we're beginning to talk about informed consent, working in higher levels of care, one of the things that I found is that levels of care are not always adequately explained to clients. And as I mentioned in this clinical orientation that we provide every client in our men's program, which is what I'm in charge of, so I'm not speaking for the women's program at my company. But we need a way, in addition to explaining like the ASAM levels of care and understanding why residential is more appropriate than PHP or IOP or even outpatient. In addition to those conversations, it's very important that we're very upfront with the services that they're being provided. And if you look at the top part, group programming hours per week. So this would be a handout that we can offer our clients so that they're very well informed. Once again, not just verbally being told what they're being offered and what each level of care is, but a visual too, and a conversation, which is very helpful when you think about the various learning methods that we all have, within us. So residential, they're getting 30 hours of therapy at minimum, which does include Saturday and Sunday as part of their weekend. And then the conversation goes that with these levels of care, you are decreasing intentionally based off the lack of need at that point, with the need for support, how much support. As they shift, they're getting fewer hours of group counseling. Okay, that's what the hours up there represent. In addition to group counseling, we see down at the bottom other services that might be provided that are supporting the recovery and treatment goals that the client is attempting to address. So this is an example here of a chart that can be put together for folks. And like I said, this is very important, especially as they're shifting down to lower levels of care. They're very well informed of, in a sense, not the best way to word it, but what they're losing in a sense with each lower level of care. One of the big shockers, at least where I work, when people shift from residential and PHP down to IOP, they are no longer receiving, at my company in particular, medication management. And so well before there's any kind of shift in level of care, if they're shifting to IOP, they're being told very well in advance that they need to be making accommodations for medication management, meaning a weekly visit with a nurse practitioner, psychiatric nurse practitioner, physician assistant, psychiatrist. It might not be weekly at IOP. It might be, of course, depending upon the acuity level. But that's also a shift too. I mean, in residential and PHP, they're experiencing once a week medication management sessions. And now they're also lessening in the frequency of those visits as well. So once again, there's a lot going on with informing folks of the process and in what they're getting. And in addition to this, when we think about ASAM levels of care, we're also thinking about as they shift, they're not just getting less support, if you will, structured support due to need. They're also getting re-exposed to certain triggers. I mean, if we think about if you have any experience in residential treatments are intentionally creating the bubble, is what actually a lot of our clients have termed it. I often talk about kind of physical boundaries with certain things, with triggers and stressors. Clients often just say it creates a bubble and it gives them the opportunity to do work that otherwise might contribute to a relapse or a slip, however you want to word that. Well, before they do any kind of shifting from residential to PHP or IOP, they need to be well aware of that bubble. A lot of holes are getting poked in that bubble, and that's very treatment center specific. So I I know various treatment centers would be formed differently, and you'd have access to different things based off that center. But for where I work, PHP, you're back in the city of Nashville. You're no longer in the woods in West Nashville. You are on Music Row. You have your cell phone again. And so mentally, it takes quite a bit of prep to think about no longer as IOC providing and this structure and boundaries for you, but how can we support you learning how to put the boundaries in place for yourself? What kind of support do you need around your cell phone, around communication with friends and family? What kind of support do you need around the places that you choose to go to, like stores, restaurants, especially when there's an encouragement to drink at certain restaurants. So it becomes those type of conversations as well. Okay, so all this is just to kind of give you an opportunity to think, not just how do I put it on paper in a narrative form or verbalize it, but how can I visually help clients understand these various levels of care. Okay? So shifting a bit now to clinical documentation, this is a shift kind of from one talking about informed consent, levels of care, to more of the kind of the overview of how documentation goes. I have this on here, not for best practices in documentation, but I actually think it's important to let clients know what this process is as well. They don't need to know the name of everything, but I think it's important for them to know that there is a process to their treatment. And so within 72 hours, and if you see down at the bottom, this is discussing that this is mainly from the perspective of residential PHP and IOP. But within 72 hours of a client admitting into treatment, they're getting a biopsychosocial assessment administered or facilitated by a clinician. That can be, LPC, LMFT, LCSW, but various clinicians are facilitating this biopsychosocial assessment that is giving us even more context, because ideally there's been a pre-admission screening. We have access to that documentation. There's likely a nurse practitioner who's facilitated a psychiatric evaluation. So all of that documentation is giving us context for the presenting issues to make a very well-informed initial treatment plan. And it is initial because it ideally is in collaboration with the client, and in higher levels of care, such as residential and PHP, that is something that can be modified, especially weekly, and ideally is at least reviewed weekly, but the opportunity to modify it as well. So within 72 hours, we have this BPS assessment completed, this initial treatment plan. We are presenting this to the client, working in collaboration with them on the goals and objectives that have been co-created. And along those lines, we have our progress notes, however many you have, based on the amount of sessions that you get with the client. But concurrently, we're completing a treatment plan review of, very thoroughly going through the goals and evaluation. Now, I will say, as a clinician, evaluating client progress is not always the most comfortable, but I found it to be a very helpful process. And I've just kind of had to work through that of not liking being evaluative, but it is important as far as making very informed decisions about the level of care that they might need to stay in or transition to later. So evaluation is important based off data, assessments, their opinion, and if I'm hopefully evaluating them based off those ASAM level of care criteria as well. So when we think about those treatment plan reviews, shifting down to the bottom of this, just a review, if you're not familiar with this, but in residential and PHP, a treatment plan review is ideally created or reviewed, modified, and evaluated every 30 days, or excuse me, every week. And then for IOP, you're completing that every 30 days as well. Now, if they're there 28 days in IOP, then you're completing the initial treatment plan review, and then in 28 days, the last week that they're with us, having a treatment plan review completed as well, so that we can put that for the discharge summary. The discharge planning, I know this might be structured differently based off center, but ideally there is some type of case management being offered. I mean, that is incredibly helpful for folks, for us, especially us as therapists, to not have to be looking up groups and therapists ourselves, but ideally we, based off the information, can provide clinical recommendations. We are able to collaborate with the case manager, and then the case manager is able to collaborate with and consult with the client to create an incredibly thorough discharge plan that supports their recovery at a lower level of care or even at the outpatient level of care when they return home. That is then followed up by post-discharge, a discharge summary, being able to write out very thoroughly, and I say thoroughly, but also concisely so that clinicians will read it, but whoever they're transitioning to following these higher levels of care, going to the outpatient level, writing a summary of the treatment modalities utilized, the treatment progress that's based off those treatment plan reviews, and especially outcomes. I mean, outpatient therapists need to know if you were appropriately facilitating assessments like the PHQ-9, the GAD or GAD-7, if you administered the BAM or BAM, especially the brief one, and then especially the Columbia. Outpatient therapists need to know were there any type of suicidal ideations present and what was the range and what kind of support is needed at that point. Okay. So like I said, I do not show clients this chart, but I am informing them each step of the way of what is happening with each type of documentation, because most of these documents have to be signed by clients. And so if they're signing them, it's very important that they're being informed of what these signatures are about and why we're asking them for them. Okay. So as far as the informed consent as well, informed consent goes, excuse me, the theory that we're operating from, I mean, is playing a significant part. If you think about client outcomes, now I'll get to how the relationship is always the better predictor of client outcomes, but in studies, especially in the 70s, the theories and techniques that you used did account for about 15% of client outcomes. That's what can be contributed to that. When we're talking about our theory, and like I said, this comes from our clinical orientations of being able to provide clients, not from a posture of expertise and this is what is right, but from a place of humility of this is the model that we utilize here for change and healing. And from our perspective, if you go to this second section, the middle section here on the slide, the ability to articulate either etiology or maintenance of issues. So it's very important for us to be able to explain to folks from our perspective why addiction develops in the first place. And if you're familiar with the Tenza model, especially for sex addiction, we speak from that quite a bit, which is very attachment theory driven, etiology and maintenance. So not only how did that presenting issue form, kind of the origin stories, but what's maintaining those issues. Now, maintenance does get a bit into systemic models as well. So systemic models, family systems are very big on like circular causality and what's maintaining an issue. And so there are various approaches, but being able to articulate in a pretty concise way from our stance, this is the posture we take towards explaining various issues. And that gives us insight into how do we intervene. Okay. Many of us practice from a pretty eclectic or integrative model. I don't think there are very few people who are just absolute purists when it comes to a theory, but it's still very important that we can provide a pretty concise explanation for how we are approaching whatever that we're addressing. That tends to give clients a framework for them to also adopt into their own thinking. It's an invitation, it's not a requirement. When we as clinicians are incredibly eclectic to the point of every session is a different theory, every presenting issue is a different model, that tends to actually create dependency on us because we always have a different answer. So they can rarely get at their own model of change and healing kind of instilled in them to be able to, when they're away from us, to be able to think back to certain interventions that they find to be helpful. So in being able to articulate and operate, for the most part, from a baseline model, we're giving them a framework for healing that they can adopt into their daily lives. I mean, very simply put, CBT could be an example if that's your explanation for etiology maintenance and provides you interventions. You're giving clients a language for understanding thoughts, emotions, behaviors, and how to intervene in a way in their daily lives of identifying and replacing negative core beliefs, replacing them with much more positive, self-empowering techniques as well. Okay. So continuing on with the treatment frame, this is just building off the previous slides of the work of Borden. And Borden was one of those, I believe he was a psychologist, who talked about, in addition to, of course, operating from a theory, making sure that there's a very strong emphasis on the relationship. And how do we do that? How do we build a very strong working alliance, which, like I said, the research shows that is where you can get most predictive in client outcomes. Above and beyond, extra therapeutic factors actually are the best predictor. So things pretty outside of our control, like client's hope, client's motivation, like I said, acuity, those things are the most attributable to outcome. But what's second, I believe it's about 33% in that moment, in that study, it's the bond. I mean, it's the relationship accounts for client outcomes. As I mentioned earlier, techniques theory accounts for about 15% of the explanation for client outcomes. So we ideally want to place the most emphasis on the relationship. And like I said, how do we do that? And he broke that into three kind of ways of thinking about it, with the bond being mutual respect, okay, between the clinician, between the client. There's felt trust, there's felt safety. Many of us learn how to operate from that. I mean, I think we as humans just embody that, but sometimes as professionals that can get a bit lost in the professional setting. So sometimes we have to come back to learning how to be very warm in that setting, be empathic, of course, with our own boundaries when it comes to thinking about compassion, fatigue, and things like that. But in addition to that bond, that's helping us set up to establish mutually agreed upon, going down to the bottom, mutually agreed upon goals, and mutually agreed upon tasks as well. So as we are forming the treatment plan, especially that initial one, which likely will be modified over time based off the level of care, but as a person is creating goals, thinking about, these are my issues, but what do I want my goals to be? It's very important that we are aligned with that and we're very upfront on how we can facilitate that. And that gets into task. So it's not only do I, as the clinician, decide with you, like, is that within my scope of practice to assist you with those goals? But the way in which I assist you, the interventions are actually about the task. And this is the importance of co-creating a treatment plan, because that treatment plan is really laying out well, what are those goals? What are those objectives? And as far as the intervention and strategies, how? How are we helping you with those stepping stones towards that big overarching goal? Do you agree with the way in which I'm saying I would typically go about that? An example of that is working where I do, very attachment theory driven. And of course, CBT, I think, will always come into account in a treatment setting due to the research and efficacy. But I had a client, as I was explaining attachment theory, he was very adamant that CBT has worked for him in the past, and he really wanted that to be a part of his the strategies involved in meeting his goals. That offered me the opportunity, because he already had a language for interventions and strategies based off goals. That afforded me the opportunity to tell him how I can integrate core beliefs work into attachment theory. And that was very satisfying for him to hear that, yes, this is attachment theory is not a model he's very well acclimated with. He agrees with kind of the premise I was setting up in terms of etiology and maintenance, but he wanted to ensure core beliefs work was going to get integrated into him addressing his depressive symptoms. So it's a wonderful opportunity to be very collaborative with their clients in establishing this treatment frame. Okay. Additionally, and this is not always the most pleasant conversation to have with clients, but it is very important to set up reasonable expectations for outcomes. And I do see people have their hands raised. Lindsey, you kind of decide if we want to save that to the end. Just let me know if you want to interject. But otherwise, I think sometimes we will wait until the last 15 minutes. So I do apologize for that. In a recent
Yes.
force. Yeah,
Sorry
go
to
ahead, Lindsey.
interrupt your flow. If you could please write in the Q&A section your question, we will get to it in the last 15 minutes.
Yeah, thank you, Lindsey. So in a recent FORSI outcome study, now this is a nationwide study of quite a few treatment centers at various levels of care. They try to integrate as many levels of care as possible, but due to time, I'm just going to briefly say, and you will get access to this slide deck, so you'll have this, and you can also look up the reference here, which they just published, I believe, a month ago. Clients who stay in treatment longer than 30 days, just overall say, just have better outcomes. And that can be a hard conversation due to resources, due to needing to go back to family. But when you look at these bullet points, we want to set clients up for success and help them to understand that it might not be more than 30 days of residential. It might be 28 days of residential, but we need to create some type of very strong aftercare plan, which might be IOP, which might be 90 and 90 with 12 steps. But we want to create a very solid discharge plan. And this study, the challenge with this study is that they did not compare just residential, but they were as inclusive as possible. So there can be different combinations of treatment. It does not have to look like residential, PHP, IOP, sober living. So, but in general, in whatever combination and blend that you do, some type of treatment for more than 30 days leads to better results. That is very important for clients to know when they do come to higher levels of care. Okay. All right. Due to time, getting into specific ethical issues. And I want you to think about, maybe not you, but in general, working in the field, people who have, you've heard about different ethical issues arising. I want you to think about which ones you think might be most common within the field. The research I'm about to show you is actually specific for licensed professional counselors. I don't know of any that blend all the various professions within the umbrella together. So this is a bit targeted here, but I think it's very common in general. Okay, so just kind of be thinking about which ones do you think are the most common when I take a sip of water. Okay. So in a recent study, like I said, this is specific for licensed professional counselors. There were over 800 violations that were studied and analyzed and put into various categories as well. So I'll give you a moment to just look through the various categories. The dark blue line is, of course, the number of violations. The total, like I said, is I think about 847, but I know it's well over 800. And then in the green, we're seeing the percentage of that based off the total. As you're reading through these, I want to point to the top three. The first one being typically more about continuing education. Sometimes those just kind of slip through the cracks. Sometimes not intentional at all in terms of not just the hours, but the categories sometimes are hard to get. You didn't get suicide prevention, you didn't get ethics. Those things come into play. But looking at the second and third one, having to do with relationships. So relationship-oriented violations tend to be the most common. And so that's setting up this next part, which we're going to get into confidentiality first, but shifting a bit into more relationship-oriented work. So I'm not basing the next part just off this study, but I just wanted to be very clear of how important it is for us to have our own boundaries and allowing other professionals whom we're working with to really understand and to help us as we're navigating the difficulty of our profession. We get very close with folks, and sometimes it's hard to see what's happening or be aware of our own feelings as well. This is where supervision can come into play. And just because we're fully licensed, supervision can still be incredibly helpful from time to time, although I get the cost is pretty unpleasant most of the time. Okay, so with confidentiality, unfortunately, this is getting into the legal aspect and does vary so much state to state. So I'm not going to really get to be specific on this. I just want to make sure that we're thinking about this and just encourage everybody in the state, jurisdiction, country that you're in to be sure that you are very well aware of what the laws are pertaining to confidentiality. Looking at this top line, when it says the limits of confidentiality, there are limits, and that needs to be discussed with clients. Sometimes that completely goes without being discussed, and then clients state something, and then that falls outside of the limits, and that creates quite the rupture. Doesn't mean that that's not okay. The rupture is probably going to happen, but ideally they're well informed. If this gets disclosed, this is something that goes outside of what I can keep in this room just between the two of us. Okay. So we do know that some are working with court-appointed clients, court-mandated, having a very thorough discussion with the client about what will be discussed with the probation officer or whoever is involved in that, the type of documentation that's being collected. Of course, any kind of duty to warn when it comes to drugs and sexually risky behaviors, such as potential transmission of STDs. And regardless, ideally, we are consulting with colleagues whenever we do disclose information. Even if it falls outside of confidentiality limits, we're still documenting that we consulted with a colleague. Yeah. When it comes to minors, of course, this once again varies state to state, but we're getting well acclimated with ages because across the states, I mean, we know 18 means an adult, but when it comes to healthcare, age matters at that point per state. So in Tennessee, 16 years old, you are given legally autonomy to make some healthcare decisions for yourself. However, when it comes to signing a contract in which payment is involved, that is not within the scope of a 16 and 17-year-old as well. So that creates very murky waters of going to a therapist, signing a contract, agreeing to pay a certain amount of money weekly without the consent of a parent. And once again, this is one of those difficult situations in which, well, what do you do? And I don't always have the answer. I think that the point of this discussion right here in particular is we ideally have access to an attorney and we consult with colleagues when we're making decisions, especially if we're working with a 16, 17-year-old and a parent or caregiver who does have right to know certain information, wants to know that. And so once again, though, informing the minor of what likely can be discussed, maybe legally what a parent has access to with their information, but this becomes part of the discussion. With families, working in higher levels of care, and even from an insurance perspective, it is incredibly important to involve the family as much as possible. With that comes the need to have a client sign a release of information. I put in here for healthy and helpful family members. We know some people we need to create boundaries around those interactions and the information that they know. But I think if you've worked in addictions, it is so encouraged and so helpful in recovery to try to involve healthy and helpful family members, or at least friends as well in that process. That comes to explaining to clients, like, we would never coerce you into signing a piece of paper that says I can talk to your spouse or partner or mom, dad, whoever's in your life, but explaining how it can really contribute to ongoing recovery, especially when they go back home and based off who is with them. Okay. So, all right. And then a no secret policy, I'm just going to say, just be mindful of that. The legal aspects of telling, especially if you're doing couples work and you say, well, I have a no secrets policy, that's getting into confidentiality issues. So I'm just going to say, consult with colleagues, consult an attorney for issues like that, but be mindful of a no secret policy if that's the stance that you're attempting to take, especially in couples work. Okay. When it comes to boundaries, of course, we're thinking about conceptualizing this in multiple ways. And I'm just kind of bringing this to light that you can conceptualize boundaries in two different ways, such as crossing boundaries, which from Sheffield's perspective is not necessarily bringing harm to a client. It's just you're engaging with the client in a way that's not typical. That might actually be through touch on the shoulder or something like that. No harm ever comes of it, but it's not something you typically do. It seems through collaboration that might be appropriate. It might even be a hug, which is obviously controversial over hugs and any kind of touch. But crossing of boundaries is just, you're thinking about, even if it doesn't bring harm, there was a bit of boundary crossing in that moment, because I don't typically do that with most clients, but I did with them. Violations are more of when harm actually is committed, and it could typically involve an ethical complaint to your board, resulting in some type of citation or unpleasant negative consequence as well. So as I was talking about with touch, just being very mindful of the setting that you're in. I mean, when I was a school counselor, I just really took gender into an account, and I know that there are various opinions on this, and so people might disagree with this. I did take the perspective of, as a man, to be a bit more cautious in any type of touch as well. Sometimes women might not take the precautions that I do, but sometimes the exact same ones. And I know it's not just men and women, gender is on a spectrum here, but you're kind of thinking about your own gender expression and how might that affect the perception of touch, and even if it's necessary, helpful, or healing in that moment, but especially still verbalizing and asking. If you feel like the need for, touch on the shoulder, something like that, ideally you're practicing boundaries of asking first rather than just engaging in it. When it comes to sexual attraction, unfortunately, that tends to be time and time again one of the most common violations found and documented by licensure boards. This happens consistently. I've had clients on both ends of this, being clients who engaged in inappropriate relations with their therapist, and therapists who have also engaged in these inappropriate relationships with clients. So it's not abnormal. We're humans. We tend to have various attraction templates, and sometimes a client might fit that. And yet, obviously, that puts us incredibly at risk for violating a person's boundaries, regardless of whether there's quote unquote consent or not. It goes against our ethical code. And so we need to, mitigate that completely, regardless of, I know sometimes ethical codes say, well, you can wait 5 years, and then technically you can. But ideally, you're always thinking about this from a stance of power as well, okay, and trying to prevent that. When it comes to self-disclosure, I would say much more commonly, and people might have different opinions than I do on this, but I think self-disclosure in addiction is so much more prevalent. I find that those who are therapists in an addiction setting often disclose they might be in their own recovery or their own experience in 12 steps, and there are always going to be different opinions on that approach and perspectives. And I think it goes to anything in therapy of sometimes you have to use, although tuition is not always a thing to use in every setting, but sometimes you kind of get the sense that to form that bond, a bit of self-disclosure might be helpful in this moment, to let them know I've been there. When they talk about 12 steps and hating it or not understanding this, you might not go into full detail, but say, if you've been in 12 steps yourselves, making that assumption. But, I remember the same confusion when I first went to a 12-step meeting and things like that. So using self-disclosure, which is considered an advanced technique because it's easy to do, which makes it sound not advanced, but it's hard to do it well and in a way that actually serves the client rather than kind of potentially our attempt to force a bond, which ultimately results in not being the most helpful with the client, us trying to show how much we relate. And then, of course, the attention shifts away from them and onto us. And then they're kind of at a place of, what do I do with that? He just disclosed his issues. Do I now comfort him? Do I say thank you? It can put a client in an awkward position, but sometimes very helpful to their healing. Okay, so I apologize for the sounds behind me. It'll pass pretty soon. But on the note of those who have done their own healing and recovery work, it can be easy to push a bit what was helpful for them in their recovery and in their healing. And that's where we need to make sure that we are operating from a theoretical model of not just getting to a place where, well, it worked for me, so it works for you. And yeah, I think even from an insurance perspective and ASAM perspective, 12 steps are a very good example of this. 12 steps have been tremendously helpful for a lot of folks. But for some, the issue of a higher power or a certain type of meeting, which might not use language that they're the most comfortable with based off their past, based off their personality, their own value system. And I think it is to be expected that 12 steps is going to be pushed for a lot of folks due to just the decades of help people have gotten from it. But us making sure that we're being very open to other ways of healing. And I mean, I think that comes into play with looking at not just 12-step meetings, but community support meetings and being very upfront with it does not have to be 12 steps. It can be various community support meetings like Smart Recovery. And then what I found some clients who do not want much to do with 12 steps might even prefer something like Dharma Recovery. So any kind of community support, us even promoting any kind of religious or spiritual groups as well as far as the recovery goes. So making sure we're not just operating from our own what helped us or what even helped other clients, but knowing that community support is very helpful in maintaining sobriety, but it being open enough where people feel like they still have, once again, that word autonomy in their treatment. Okay. The other thing that I briefly want to mention is that sometimes, we as counselors, we have our own mental health to address. Sometimes there might be a slip, might be a full-blown relapse. I know there's different terminologies for that, but being very mindful of if that were to happen, that we have a game plan, not just if that were to happen, but how are we actually addressing our own mental health, our own well-being? And if there are any kind of relapses which create impairment, what are the measures that we need to take? And ideally, having our own therapist, our own sponsor, whoever or whichever professional we want to involve in that process, but not deciding all by ourselves, but allowing other people to be involved in that decision-making as well. Okay. So as we begin to conclude, I definitely want to touch on just competency when it comes to cultural considerations in these aspects right here. Regardless of race, ethnicity, all of us are multicultural beings. I mean, we have families that we were raised by, which helped us to form our own value system as well. And so with every individual that we discuss, kind of goes back to 12-step meetings as well. Whatever type of meeting or healing that we received, understanding that we always want clients to feel like they have autonomy over their recovery and their healing process. We can get more targeted into when we think back, because most of us probably had to take a multicultural class, thinking back to understanding that there might be certain races or cultures that might have a propensity towards a certain way of healing, and as best as possible, informing us of those ways in which they can get healing. We have the opportunity, and it's been something that I kind of got to be a part of and became amazed about, was the therapists who we have who are of Indigenous descent and get to bring in those practices. And so there was a time at the company where we had quite a few folks who lived on reservations actually being a preferred treatment center because their way of healing was so integrated into more kind of traditional therapeutic modalities. So I know that's very dependent upon treatment centers, what can be offered, but us getting well educated on how do various cultures heal and inviting that. We might not we'll never know all of it. And that's where I think there's been a shift away from cultural competency, like it says up here, to cultural humility. We're always learning as well how to bring about healing. Okay. This is just a reminder. We get, I think this gets well enforced as we go through educational programs to get to know ourselves. I think they've really abandoned ship with the whole idea that we can ever just be a blank slate. We are human beings. We will always have bias that we need to become aware of and need to address, and engage in ethical bracketing is what many have shifted to an understanding of we are still human beings, and it's okay that we have values. I'm not saying it's okay that we have bias, but we have our values, recognizing those. They're not going away. And so there are going to be certain behaviors that we hear about that do not align with our value system. I think that comes into play with addiction, that you might have the value that states certain substances should not be engaged in, but you get a client whose value system says that that behavior is fine. I just need to engage in harm reduction or moderation. I think we all end up having opinions about, can moderation actually exist? But us even bracketing that and recognizing that, having conversations with colleagues when that issue in particular is influencing or even creating a bit of harm in the situation. And that very much leads into self-awareness when it comes to this aspect of us. So important. We spend time in our own therapy and supervision and our own community support meetings, really getting to know ourselves. What are our triggers? What are our beliefs when it comes to healing? And so the more aware I am in a moment of who I am, what I believe, how I'm affected, the more I can understand when I'm with a client, when those aspects are influencing the words that I'm saying or the philosophy that I'm taking. And I'm shifting away really from research and evidence and into more of my personal values coming into play. So it's very important that we develop that awareness of self to really do no harm for clients, to honor them, to respect them, and to instill the autonomy that we've been talking about during this time. Okay? So that concludes presentation part, and I know that that gives us a little bit more than 15 minutes, but Lindsey will help out as far as questions go. So I know we might not get to all of them, and I'll do my best. When it comes to legal and ethical questions, state to state, I might have to defer, but I'll do my best in trying to navigate those questions.
Awesome.
Thank you, Lindsey.
Thank you, William. Of course. All right, let's get to the first one. And this might be one that you have to defer just because it sounds like a state-by-state question, but I'll ask it anyway just in case. The question says, are there requirements in some states to break confidentiality with drugs and sex activity?
Well, that definitely gets into the situation. I know everything is like, it depends. It gets into, are they court mandated? And does that documentation then show that you have to report that to the probation officer? There are some grant programs, unfortunately, that are written in such a way where they get two strikes. I know that's not the best way to word that, but kind of two strikes of using before they no longer get to be a part of that program. That's one way to answer that. I don't think if someone's just simply, if they're an adult and using illegal substances, if that's the question, no, typically, unless there's a situation I'm not thinking of. But, if we have a release, then I'm thinking of any kind of sexual contact where something might get transmitted, then that does get into duty to warn. But duty to warn is getting state by state, that differs and changing. Tennessee just had, don't know if it passed yet, but duty to warn, a change in that was just proposed in Tennessee. So this is why it gets so specific and why I kind of defer answering questions like that right away.
All right, thank you. The next question, I do walk and talk therapy where a client combined with physical fitness and wellness component while addressing their mental health concerns. The therapeutic environment is outside, usually in a park. Is there any legal issues using nature walk and talk therapy in the park? This is thinking of HIPAA partially and the legality of that.
Yeah, absolutely. Yeah, there's, I guess you could say there's always risk, but I think that the main aspect of that is given that you have, everything that you need to operate as an independent clinician. So aside from those types of things, I think that this comes down to informed consent. Just as I talked about, of if you're in a public setting, that needs to be both written in your informed consent, that there can be no guarantee of confidentiality, and that becomes a discussion. Now, I don't know though if, regardless of whether they sign an informed consent and someone still overhears it and there's harm, if just because they signed that and that was stated, if that mitigates any kind of risk on your part, I don't know that. This is my concern with questions like this, of like, consult your attorney. But that would be my best guess, would be just on your end, trying to inform them of all the risk in engaging in private information in a public setting.
Someone wants to know, can you share what smart recovery is? I heard about it from a client today and was planning to research it.
Yeah, so and I am not the well-versed in it myself when it comes to smart recovery, but many people think of smart recovery, very easy to look up, but where people do not want so much of an emphasis on a higher power, as far as their recovery goes, that tends to be a preferred alternative to a 12-step approach.
Great. And someone just wrote in there to smartrecovery.org. Y'all, if you want to research it, that's
Thank
where you
you.
can
Yeah.
go to be able to research more about it, of course.
Yeah.
With working with minors living in two homes due to separation or divorce, can one parent sign consent for treatment for the minor child, or does both parents need to provide consent for treatment of that minor?
Yeah, that is a great question. And that typically depends, once again, I'm so sorry, y'all. It depends on the state. And then it also gets into, if there's custody paperwork, that is often defined in that custody paperwork. So that's where you as a clinician need to request custody paperwork. And that becomes something that I don't think a lot of clinicians do, like because I think the stance that we often take is we want people to get the help that they need. And it's so like heartbreaking sometimes to say, well, I can't see you because I don't have that paperwork, or turning somebody away. And that tends to be pretty heartbreaking to deny somebody. But custody paperwork for our own protection is very important to have and to read through very thoroughly on what rights does that caregiver or parent have when it comes to that. I dealt with that as a school counselor all the time when I was trying to get student services. Yeah.
Yeah. The last question we have, which I can actually answer, is the IOP program face-to-face or Zoom? We are currently all in person, currently with our IOP program, everybody. So thank you so much for your questions. William, thank you so much for an informative presentation. Reminders, y'all, please have your evaluation completed by next Wednesday. We will be sending the PowerPoint that William just went over. We'll be sending the recording of this presentation, as well as your certificates by next Wednesday, June 26th, for your continuing education credits. Well, thanks everybody. Have a great rest of your day, and we'll hope to see you soon. Bye-bye.
Thank you. Bye.